this is a different skill set than traditional nursing. It's much more oriented towards social interaction as opposed to medical. So you do have children who have tracheotomies and G-tubes and all of those different things that require a certain amount of attention. But let's face it, a parent can do that. And we do. You don't need a nurse to do that. And a lot of the nurses, one of the reasons they move out, one of the reasons I heard the most was, I'm not using my skills. So wound care, IVs, all those different aspects of nursing in a hospital environment, they were not able to use here, and that they felt was not okay if they were career nurses of a particular sort. So they would move out.
So it wasn't technical enough. Maybe.
Yeah. Yeah. And some people don't like social. They like the floor. I got to go from room to room to room. I take blood pressure. I do this. I do this. I do this. Here you're in an environment with one person all day. The other thing is it's the vulnerability of being in alone in a caregiving situation. And some situations aren't all ideal. I've talked to some nurses who have dealt with, spousal issues, divorce and separation, people pounding on doors and whether they're allowed to let them in or not, that sort of thing definitely has come up. So that is one of the complaints too. When I was reading about why they are so challenged with community care and filling those positions, aside from the pay, was the isolation. Either issues of safety, issues of, or not knowing who to listen to. The parent is in charge of the child's well-being. And what if, as a nurse, your perspective of that doesn't jive with the parent? So you're either in conflict with the parent, or you're just saying, okay, I'll do whatever they say, in which case then you become uncomfortable in yourself, and people then leave if it becomes too difficult.
So in some respects it requires a more mature, experienced person to come into the home and be able to manage their role,
yes,
as well as their tasks.
Yes. You're also in another person's personal space.
Yes.
So whatever family, the fights and the spats and the things that happen every day with family, you don't even have to be any kind of crisis, just the regular things. You're there, you're hearing it, you're in there, and all of that, it requires, maturity and a respect and understanding of where your boundaries, very clear understanding of boundaries. Where are my boundaries? Where do I step in? Where do I step out? And I've seen, the extremes where people they're so out of it that they can't possibly work in the environment. And I've seen people who are like in your personal space, involving themselves in discussions. It's a tricky. I have a lot of respect for the women who can do this, and it is women. I've seen one man in all of it, and he couldn't do it. He really wanted a different focus, much more administrative oriented, which was interesting.
So how long did it take you to get accustomed to having people come into the house?
It depended, I didn't find it too bad. It wasn't being accustomed to the people in the house so much as the person herself or himself was there. It was the individual. And some people were more difficult to deal with. Mixed in with that, though, is what's changed for me in terms of how I care for Sophie, is that in the initial stages of dealing with her, she was much more compromised than she is now, much more medically fragile, nonverbal, not able to spend a lot of time in her chair. She was on 20-hour feeds at the time. And there was this overwhelming protection, and that nobody could do it as well as me or my husband at the time. And in some cases that was true. There were some really poor caregivers. In other cases that was just being parents getting used to that, caring for somebody who's fragile like that, who requires all that attention. So dealing with someone in your space had so many layers to it. Either you just didn't like them. They're just people you don't get along with. And that's, that's understandable. The other thing was genuinely poor care. People were inattentive and just bad at their jobs. That was another layer. And then people who might be good at their jobs, but maybe not so good at keeping their space. Back and forth there. That could usually be addressed with a conversation, an adult conversation, and that was okay. But the other side of it And I think the most significant aspect was my attitude towards my daughter at that time, and that I was so protective of her that it was really, nobody really could do as good a job as me. And so the tendency was, well, get out. I'll just do it myself, which is, in the long run, not a good thing. Leads to quite a few problems. There was one nurse who, and this Sophie's 15 at this time, and so she had been 7 years in post-stroke, and the caregiver, the nurse, was used to dealing with babies, and so she spoke to Sophie in a very sing-song tone, like a little baby, and she would ask her the inane questions like, "What's your name? Who is that? And can you count to 3?" And one day, finally, I had spoken to her, and I had said to her, Sophie is 15, and she's a teenager. And this woman was a fairly good caregiver, so I was hesitant to kind of just say, well, get out. But I knew the language was a problem, the way she treated her. But one day, she said, "Sophie, can you count to 3? And Sophie looked at her and had learned to count from another caregiver in German, and she learned to count in French from me. And she just hauled off, and she counted to 10 in German, and then she counted to 10 in French to this woman. And I thought, wow, if that doesn't say get lost, I don't know what does. And so I did. I fired the nurse after that.
Right.
I thought, that's offensive. Like that, she's really offended by this. And my daughter Amelia witnessed this too, and she said, yes. After that, for me, the caregiver, I started watching how she reacted to the caregivers and stopped immediately assuming what I liked or didn't like, she liked or didn't like. And it made a big difference, because now there have been caregivers here that I thought, ugh, whatever you're doing, I don't like. But Sophie clearly liked what they were doing. And I thought, okay, I have to bow to that. If they're obviously, I mean, there's a line where
Sure.
inept caregivers are inept caregivers. They don't do it right, whatever. But that is very rarely the situation now. Now it's like, well, you may rub me a little bit the wrong way, but man, Sophie really likes you, and you really interact well with her, and that's the judge now. Definitely, the atmosphere in the home was the overseers of the caregivers. So it was.
Like a little mini corporation.
Yeah, and I would say a waste of energy. In retrospect, tremendous waste of energy.
And why is that?
There were really good people working for us that we got rid of. Because of the because of the way we approached Sophie and her life. We got so caught up. And I'll give you the perfect example of a thing that would get us stressed out. And I'm going to say us because I wasn't alone at the time. I'm a single mom now, and I've been a single mom since 2011. Okay. Prior to that, I was with my husband. And I'm careful. I don't want to speak out of turn for him. So there wasn't us there, but I was definitely participating in that. Okay. The way they hung the bag with the tubing, I would say bagel, and you know exactly what I mean. And you hang up the tubing, and if they didn't do that right, we would get very annoyed. And if the syringes were put the wrong way, and they should have been done like this, and there was water in the syringes, and oh my gosh, isn't that appalling? And all these things, the minutia became the most important aspect of care. Not the most important, a significant, and it didn't matter. None of that mattered. And what happens is we became entrenched in this rigid perspective as to how things had to be, and that was you had to imitate the parental caregiving model exactly. There was no room for any sort of deviation from that. If we did it this way, you did it this way. If it turned her this way, you turned her this way. If you positioned her, everybody had to do exactly the same thing. It had to be repeated across the board. So you can imagine that for that to happen is almost impossible. And so we went through a slew of staff. And a lot of people did not want to come to our home. That I only found out afterwards.
Right.
And to release, it became an awareness of my own as a teacher of small children in a Montessori school, where the best school environments were the ones where, because a Montessori environment is very rigid in a way. You have to establish certain things in a certain way based on the Montessori method. The best environments were where the teachers had, within that structure, the freedom to be themselves and to bring their gifts to that environment. That I had to translate into the caregiving environment for my daughter. To say that these people come in and there's going to be things they don't do exactly like me. And I have to know where the line is, where that matters and where that doesn't matter. So if, for instance, Sophie was particularly sensitive to noise, it would not be appropriate for the nurse to be noisy. Whether that's an opinion or not, it's not an opinion, that's just a fact. That mattered. But whether the syringes were this way or that way, whether this was hung that way or that way, whether when they turned Sophie they said this word or not that word, those things had to get all washed away, and then I had to let people be themselves. And when that happened, the caregiving quality just went like that, because they didn't feel all stressed out, being watched constantly. I would walk away and leave them alone. There was a situation in a school that was into the full inclusion model, and the particular individual liked this toy, and she always had this toy with her. And the powers that be on the outside said, well, she can't have that toy. She's in high school. It's not age appropriate. Right. We're going to give her an iPod. Okay, well, the result, like what would happen with that particular individual and the iPod is chewing on the earpieces and throwing it on the floor. There was no function for the iPod in that particular individual's life. So that was considered an age-appropriate move for this person, but it's not appropriate for that person.
Right.
So that is really tricky, because some individuals will always like to hear Barney for the rest of their lives. And do we deprive them of that if it gives them pleasure and joy? I don't think so. However, in going over that, if you never introduce them to anything but Barney, what else are they going to like? And I think that's where we run into problems. It's like, they love this. We don't take it away from them. It's like, no, but why don't you try some other things and see what happens? And that's definitely what I've seen. So to initiate separation, which the children usually do to the parent, the role is reversed. Mm-hmm. So the parent now has to say, I'm going to experiment with separation, in the sense that I'm going to try to honor them as individuals and what they may or may not like. And that means I'm going to have to think, if I'm going to try this, I'm going to try that, I'm going to do this, I'm going to leave them with someone else, and I'm going to try different music. That kind of thing. So it takes each individual, you look at them individually, you can't say, this is age appropriate. Mm-hmm. Try it. And then say, oh, that's not age appropriate. That obviously, it's not appropriate for them. Age appropriate, yes. Appropriate for them, no. Then make that decision, but keep bringing it on. There's different extremes. Some people, they'll make the child really funky looking, or some people will go really high end so that they're impeccably dressed at all times. I've seen that, like the Gap everything, and the high end, really nice, beautifully dressed. And I can't say, I get that. Because then what I think in terms of clothing, and I guess this is very, very narrow, but very much in terms of clothing, what I remember pre-disability, before Sophie became disabled, and I was just among the ignorant, unwashed masses like everyone else with that, I remember noticing that people with severe disabilities had their pants on crooked all the time. And I didn't know why. Why do these people always have their pants on crooked? Then Sophie comes along, and I realize why. It's because they're wearing briefs. And people slide on their pants and then just leave them. And that just bothered me so much. Mm-hmm. Put their pants on right. It's the one little thing that tells you they're wearing diapers. Put their pants on right. So the seam in the right place, for crying out. Isn't that funny? And that's so bugs me today. I want pants right on that.
But would there also be another little subversive side of you that says, yeah, she's wearing diapers? What are you going to do about it?
I guess, and I think probably one of you talk about overthinking, because for the more I learn about disability rights and all these different things, I get it and I understand it's like, you know, to heck with the world and how you see my kid. But the fact of the matter is, I want to present to you the thing that will offend you the least, right, so that you can get over everything at least to the degree. So the less that that you have to get over in interacting with my child, the better.
Right.
And if that means that my child, impeccably dressed, gives you something that you can at least deal with, that matters, and I'll do that,
right,
because there's always so much already to get over for other people to deal with our kids and our, you know, these people. It's just, there's so much. It's like, okay, at least you don't have to deal with get over their clothes. And the other side of it is too, you can actually be disrespectful to an individual by not dressing them well. It's like, what do they care what they're wearing? Yeah. It's dirty, it's stained, it's improperly put on, it doesn't fit. That is a neglect. See, that's the other end of it, and that's not okay either. I remember understanding that because I was watching something from, I don't know if I can say this, but it was from Blurview. It was a video, and it was awesome. And they had this child with severe cerebral palsy, and they were going to make this child walk. And they had the walker, and the child could walk in the walker after 29 Botox injections every so often. And they videoed this poor child getting videoed. Sorry.
Yeah, I remember this. I remember it was a little boy, right? Yeah.
He was 5 or so, 4 or 5, and they had him in his underwear, and they had him on a table, and they were injecting him with Botox injections, which I know are painful, and to get him to walk. And what I found offensive, first of all, was that they were videotaping that, first of all, and put it on for people to see. I thought that was offensive and a complete lag. Like, that was not showing good judgment in terms of providing privacy for that individual. However, what I found struck me at that moment in time was the degree to which we were, what was being done there to make a child walk, and had they ever sat down with the parents and said, this child will be able to walk like this using this method for the rest of their life. Or if they had analyzed the situation and said, if we do this for X number of years, chances are the motor skills will develop and that your child will be able to walk with assistance like a walker, and we won't need to use these Botox injections and so on and so forth. If there was a long-term motor development occurring in that, maybe that was a good idea. What about fitting them for an awesome wheelchair that was really comfortable and that caught them around? That's a value judgment, as a wheelchair is awful and walking is better. Especially in that particular situation where making that child walk required extreme measures. Mm-hmm. On the other hand, there's a level of therapy where I'm big on communication, because I think if you can find a way to get a child to communicate, whether it's just a yes, no, sticking your tongue out, whatever, really helps that child. It's freeing for that individual. It's not about, oh my God, my child can communicate with me and I feel relieved. It's more like that person can now express likes or dislikes. So I've always approached therapy in terms of what will make that person more comfortable, what will make that person have more autonomy. But there's a line, like if it's going to take, if autonomy means has to walk, has to have 29 Botox injections every year for 25 years, that's to me, not okay. That's not okay, period. But it took me 2 years to train Sophie how to swallow. And that paid off big time. She doesn't need a G-tube now. I mean, she has it for supplementation of fluid and medication, but she eats 3 meals a day, and that gives her a tremendous amount of freedom in terms of, and better health, because she can eat. Because G-tube fed is harder. It's harder to maintain good health with G-tube fed. So, yeah, but I didn't know at the time when I embarked on that how long it would take and if it would pay off and So it's tricky because some of these things take a long time and a lot of effort. Many people with intellectual disabilities, even mildly so, behave inappropriately in society. So for instance, they will walk up to you and say hello in very enthusiastic tone, and you don't know who they are. And these are not social mores that we find acceptable. So, and I've had this happen to me. I remember, and this was before Sophie became disabled. I had an individual with Down syndrome approach me at a market, and just said, "Hi, how are you?" And he was just right into it, and it was actually, I found it fun, and I engaged that person for a few minutes, and we moved on. But I could see that with other people, that would be incredibly uncomfortable, and the tendency is to look away or walk away, and not say anything, and it's not polite, or they don't know what to do. To be perfectly honest, they really don't know. It destroys what we understand as appropriate social interaction. It's very professional or distant and so on.
Right, with
when there are certain boundaries, and some people with intellectual disabilities cross those boundaries all the time. They cross physical boundaries, they cross the verbal boundaries, all those kinds of things. So then you combine the two with children like mine who have intellectual and physical disabilities. So you just the aesthetic that we accept is gone, the social interaction is gone. And people who don't know anything about it are at a loss to interact at all. So you get kind of extremes where there's the I'm going to ignore you and pretend and not look, or the over-approaching, because that's what I saw with my daughter. Was people walk right up to you and touch and say hello, and they talk, or they'll talk too loud, and they go into that mode. And I think that's also an attempt to be comfortable, and they're not, to be nice. I appreciate the attempts, right? I don't take offense at that, but because it's a lack of education. If you see someone in a wheelchair, and they just look like someone, a normal person in a wheelchair, it doesn't really bother people. But when you get more and more and more severe disability, then you're getting into the aesthetic of the body, and twisted movements, sounds, drooling, all those things that come with it, that sets people off, okay? And that requires, that's a social, cultural, what we consider to be beautiful, attractive, appealing. And we have to move beyond that and say, okay, I'm going to just kind of let that go and come up to a new understanding of the physical body and what it means, if anything at all, in terms of aesthetics.
I wonder if it's also class related. Because the way you describe the unappealingness of disability, the opposite of that is this poise, right, and symmetry.
Mm-hmm.
And in my experience, the most disadvantaged people I have met are the ones most accepting of Owen.
Mm-hmm. That makes sense.
Yeah.
And the equipment, too, that comes with it is not aesthetic.
Right.
It's really hard to hide a lift in your home and make it look appealing. Mm-hmm. Throw a doily on it. One of the nurses that works with my daughter, I see she sees more in some interactions. She sees more happening than is actually happening. It's kind of endearing in this situation. It's not inappropriate or unacceptable. It's not harmful. That's a good word. Thank you.
Do you think it's possible for parents to
yes.
behave that way too?
I think sometimes there's this deep desire to indicate that the person with disabilities has so much going on that maybe we can't see. And with that kind of show, like you say, it's like this person, they do get it. They really, really do get it. They're trying to prove a point, and it's awkward. And I think you have to be very comfortable with yourself and very comfortable with your child, adult or otherwise, to just let that go and know. It took me some time to reach that point myself, maybe not to a tremendous degree, but there was definitely a desire at one point to show people she really does get this. She really does understand that. This really is going on. I think it was in more subtle ways maybe. But over time, I've reached a point where I can say, I really don't care. If you don't think or don't see it, I don't care. The people I deal with, for the most part, are very genuine, and they don't need to. But then our kids are older. Mm-hmm. Some people need to be accommodated in very quiet, private places. And again, activism that is geared towards community involvement and community living, which addresses a lot of physical barriers and so on. Now I'm seeing a problem with that push, which affects those people who require very specific living environments that are quiet and controlled and minimal. Stimulation isn't too much. That's another. That, I think, is probably the biggest problem with disability, too, is that it's not a thing. It's not skin color. It's not sexuality. It's all these things. Mm-hmm. And how do we come together? Because a person who is cognitively capable in their wheelchair or their whatever it is they require to help them for their mobility wants a job, and so on and so forth. Anne MacDonald, who's the big story, she was so severely disabled with CP that they automatically assumed she was also mentally deficient, and of course was left in an institution until she eventually, a caregiver found her, and this was in Australia, I believe, and eventually the happy ending is that she gets after a huge fight to prove that she was cognitively capable, she has now a college degree, and everybody's happy. That's great. See, we can never take for granted the intellectual capabilities that are within. It's like, look, my daughter's never going to get a college degree, so that's not there. It's not going to happen. Does that mean that you guys won't fight for her? Either, like, we still want that intellect. It's where the arguments, a lot of them go. It's like, for instance, if you're talking about the Ashley treatment, where it's like the cognitive line is where they draw, well, we won't do it if intellectually we can prove that they're okay. That's not right either. So that means if they're not okay, what we say is okay intellectually, that we can do this stuff to them, it's still the benchmark, even within the disability community. And we have to stop that. It's true, you have to assume competence in every way, shape, and form. But there is the reality of severe intellectual disability. And so let's find out what that means. We can go through life that way, and that's cool, that's okay, it can be good. We need to explore that reality as well, as much as possible. And because it will enrich not only those with severe intellectual disabilities, but people with dementia. Okay? So the minute cognitive ability is affected, we can't write people off.